when it comes to chest pain, okay,
Dr. Sam, can I ask a quick question regarding the exam?
yes.
Uh, should we be expecting images of the chest? And if so, like how many maybe? Are there a lot of images?
Yeah, there's gonna be a lot of images. A lot. A lot. Yeah, a lot of them, you know. And I think most of the images actually are in your PowerPoints. So I recommend that you know all of the images, on your PowerPoints. Any other questions about the exam on Thursday before I get started?
Do we need to know EKGs? Like how to
Uh,
do we need to read them?
no, no, no,
Okay.
you don't have to do anything about EKG. When it comes to medical imaging one, I'm sorry, when it comes to IMED one, yes, you have to know EKG. Okay. So 50 questions on the exam. If you study very well and you understand the material and you listen and take a really good note after today, I think there's no reason why you should spend the entire 1 hour, 20 minutes for this exam. I think some of you guys will be done in 30 minutes. It's that straightforward. But again, you have to know the material. Okay, so real quick. So when it comes to chest pain, a lot of things called chest pain. All right. For example, acute coronary syndrome, stable, unstable, Prince-Metal, and MI. Okay. So if I tell you a patient is having chest pain, and I'm just testing you now, just kind of see where you guys are. If I tell you a patient is having chest pain in the epigastric area, what could it be? Anyone?
MI.
GERD.
GERD, MI, right? So what if I tell you the EKG is normal? Okay. The cardiac enzymes are normal. Again, these are the kind of type questions you're going to be getting. So I'm just trying to make sure you guys get this, right? Cardiac enzyme is normal. Okay. EKG is normal. What's your diagnosis now?
Costochondritis.
You said GERD and MI, epigastric pain. Which
GERD.
one is it?
GERD.
Exactly. So what if I tell you this patient's having chest pain and you give him I don't know, you give them H1 blocker, ranitidine, okay, and they feel better right away. What's your diagnosis?
GERD.
Good, exactly.
Pylori.
Exactly. What about this? You have a patient that is having severe chest pain, and they have positive HSV3. What could be causing the chest pain?
Shingles?
Shingles. There you go. What if I tell you a patient, presents with chest pain and they are tearing pain ascending to the upper arm, especially to the back. Okay.
Abdominal
Aortic dissection.
Aortic dissection. Do you guys see what you guys are doing? I'm giving you clues and you guys could just break it down. That's exactly what I want you guys to do on the exam. By the way, can you give me 3 different diagnoses that could give you chest pain that is radiating to lower back, radiating to the back? Chest pain radiating to the back.
MI, aortic dissection, and maybe costochondritis.
Muscle tear.
Esophageal rupture.
Esophageal rupture. Thank you so much. Esophageal rupture.
Pancreatitis.
Aortic dissection. Okay. Anything else?
Pancreatitis.
Pancreatitis also could do that sometimes. Anything else?
Pericarditis.
Pericarditis. So basically, on the exam, what I want you to do is just kind of like list, possible causes of things that could cause pain that is radiating to this area. Okay. And what you have to do is just kind of differentiate, So if I tell you a patient is having severe chest pain due to a phobia, right, to, I don't know, snake.
Panic attack.
Anxiety.
Panic attack, okay. What about if I tell you a patient is having severe chest pain, paretic chest pain, shortness of breath, tachycardic, hemoptysis,
Possibly maybe a pulmonary embolism.
pulmonary embolism. There you go. So you guys got it. Excellent. Beautiful. So I need you to pay close attention to what I'm saying. This is the area that's going to get you guys. This area, chest pain, is going to be the difference between getting 100 and getting 80. I want you to get 100. If you guys know me, I want you to get 100. But I just want you to demonstrate to me that you understand the material. So when it comes to all chest pain, listen to me, all chest pain, the first thing you have to do is to get a good Eastern physical, right? The next thing you have to do, anytime you see chest pain, you are doing EKG. Agree? Chest pain, good Eastern physical, you get an EKG right away. After your EKG, you want to get your cardiac enzyme. After your cardiac enzyme, you want to get a chest X-ray and go down the line. And then if everything is negative, you want to rule out everything else, GI, dermatological causes and whatnot. Remember, I just said that all chest pain, you got to do EKG. Except for one, I'm trying to pay attention to this. If you think that patient has pneumothorax, does anybody know what that means? Pneumothorax? What is it?
Air in the pleural cavity.
Air in the pleural cavity, air in the lungs. Okay. If you think you have, okay, pneumothorax, and when we get to, when we get there, I'll kind of help you out a little bit to kind of show you how to diagnose pneumothorax clinically. But if you think you have pneumothorax, right, the first thing you're doing is what?
Chest X-ray.
Sir?
Oh, no.
Decompression, maybe.
Decompression, right there on there. Again, we're going to focus on this when we get to EMED. You got to put a chest tube into that lungs and drain that air. Then after that, you're going to get your chest X-ray. Then after that, you're going to get your EKG. Then after that, you're going to get a chest CT. Very important. You need to know that. You need to know that.
Dr.
Okay?
Sam,
Yes.
wouldn't that depend on if the patient has like a tension pneumothorax or like a non-tension pneumothorax?
That's a great question. There are some pneumothorax that you just gotta just watch, evaluate them. You don't have to do anything. That's a little advanced. When we get to IMED 1, we'll discuss that. But for the sake of this course, for right now, anytime you're thinking that you might have pneumothorax, the first you want to do is do needle decompression. Then after that, you want to check for your placement to make your tube is where it's supposed to be. Get a chest X-ray. Then you go EKG. That's the only thing you have to reverse. Now, someone just asked me, doesn't that depend on what kind of pneumothorax you have? You have spontaneous pneumothorax, and you also have something called tension pneumothorax. A tension pneumothorax, when you have so much hair, the air is so big, or the fluid is so big in the lung that is pushing the mediastinum into the medial or to the lateral. Obviously with that one, that's an emergency. You got to decompress it right away. But for right now, anytime you're thinking you have pneumothorax, okay, do me a favor. Do not get a, what do you call it? EKG first, okay? You want to need decompression, then you want to do your chest X-ray and kind of go reverse like that. Any questions? What is the number one cause of spontaneous pneumothorax?
Smoking.
Smoking, vaping, and stuff like that. So again, on your board exam, when you're hearing things like young people that is vaping, smoking, and they cough, and after that coughing, they start having chest pain, and you notice that they're wheezing, upper resonance, okay? So basically what you want to do is you want to do a needle decompression first, get a chest X-ray and do your EKG. Anyway, what I'm trying to say is, listen to me. What I'm trying to say is when you have chest pain, the first thing you have to do is to do your EKG, okay? And the second thing you have to do, obviously, is to get your cardiac enzyme, then you go down the line and stuff like that. Any questions about that? Anything? No questions?
No.
Okay. Let's see. Okay. So again, reinforcing it all the time. You want to get your EKG. Now there is something called, stable angina, unstable angina. I'll discuss that for a few minutes, and we'll go from there. So basically, if you're having chest pain, EKG first. When you have stable angina, one of the biggest problem with nitro is that it will pretty much calm down the muscle, the smooth muscle. It will calm it down. It reduce pain to the area. Unfortunately, when you calm down the smooth muscles or the skeletal muscles with the nitro, that's what it does. What's going to happen is that you're going to get a false negative EKG. Okay, you're not going to get a true EKG. So that's why they always say, even though the patient's having chest pain and you are tempted to give him something to help him that pain, don't do it. Do EKG first, then not to give him nitro or give him some treatment, give him some pain medication. But always want to try your possible best not to give him pain medication right away until you kind of find out and you know exactly what you're dealing with. Okay? Now, another clue I wanted to give you here is when you have pleuritic pain. When you hear the word pleuritic pain, these are the diagnoses that you should have. So I want you to write this down, okay? Pleuritic pain, think of pericarditis, PE, pleurisy, or pneumothorax, okay? Very important, all right?
Okay. So you're telling me whatever I
if
do,
you have a chest pain that is radiating to the left arm, chest pain radiating to the left arm, and it feels like an elephant sitting on the patient's chest. The patient is telling you that. I feel like an elephant is sitting on my chest. And the pain is radiating to the left arm, radiating to the left jaw. Okay. What do you think is happening?
MI.
MI.
That's right. That's right. So I want you to write this down. Okay. Basically, there are 6 life-threatening causes of chest pain. Okay. And the mnemonic that I have, is my mnemonic. So I'm not sure if you want to develop yours. It's called CAPE, like Cape Town, like in South Africa, CAPE. Okay. Can anybody want to tell me what does C stand for? It's a life-threatening condition.
Cardiac tamponade, maybe?
So take your time. I'm going to tell you exactly what they are. Okay. So cardiac ischemia. So when you have your MI, your angina, that's your first one. Okay. Life-threatening. Aortic dissection. Okay. Pneumothorax. PE. Pericarditis. Question for you. How can you differentiate between pericarditis, okay, and MI?
Pericarditis has
The friction rub.
Say it again.
The friction rub is
The
pericarditis.
friction rub. Perfect. The friction rub. But again, the most important thing is clinically, these people, they get better when they change their position. So anytime you have a patient that's got some kind of viral infection, so in the stem of the question, this patient was exposed to flu virus or some kind of viral infection, right? And after that, they started developing friction rub, or they're having some kind of chest pain. And that chest pain gets worse when they lay down on the floor. But once they get up and change position, the pain gets better. That is a classic presentation of pericarditis, whereby when it comes to MI, it doesn't matter. Are you laying down? Are you up? It doesn't matter. This pain is continuous. Okay. So MI is a continuous pain, whereby pericarditis, especially acute pericarditis, when you lay down, the pain is crazy. But when you get up, the pain gets better. Okay. So a change of position will make the pain better. Okay. With pericarditis. There's another condition, pancreatitis. Also, when you lay down, the pain is worse. When you get up, it gets better. And pancreatitis could also cause you chest pain, right? The best way to differentiate between pancreatitis and pericarditis is to do your enzyme test, your amylase and your lipase. So if your amylase and lipase are positive, then you know you're dealing with the pancreatitis. If they are negative, you're probably dealing with acute pericarditis. Okay? All right. So when you see a patient like this with a positive Levine sign, what does that mean?
Acute MI.
Acute MI. Good job. So real quick, I'm not going to go into depth about this. I just want you guys to understand this. For people in medicine, we talked about something called intermittent claudication. And also we talked about critical ischemia and acute ischemia. So your stable angina, okay, what is an angina? Angina just means that a narrowing of the coronary artery, okay? What's a coronary artery? You guys know a coronary artery. We have the right coronary artery. We have the left coronary artery, which branches out to circumflex. And you guys know that in anatomy. You guys just took the board exam, right? So when these coronary arteries are blocked or narrowed, okay, that's when you have your angina, okay? So we have something called a stable angina, and we have something called unstable angina. How do you differentiate between those two? Okay, the way to differentiate between those two is a stable angina is a chest pain, okay, that is occurring with exertion. So that means you are doing, let's for example, you're shoveling snow, they start having chest pain. You are running instead of having chest pain. You are lifting heavy boxes for like a couple of hours instead of having chest pain. That's your stable angina, right? Unstable angina is pretty much a continuation of stable angina. So those people that have a history of stable angina. So before, you need exercise or something to stimulate the chest pain. But with the unstable angina, okay, this pain is at rest. This pain could happen at any time. Before, this pain is when you are doing some kind of exertional exercise or stuff, you know, but now at rest, you're having this pain. And on top of that, this pain is increasing in frequency and it's getting worse, okay, at all times. So anytime you have a chest pain, right, with a negative EKG most of the time and negative cardiac enzyme, all right, and the pain only starts after some kind of exercise, some kind of activity, that's your stable angina. If the pain is there, even at rest, okay, and it's increasing in frequency, that's unstable angina, okay? I just want you to know the diagnose, just know that, and that's it. Don't worry about everything else. We'll teach you guys everything else in EMED, okay? So that's that. So stable, just keep going, take your time. Okay, this is unstable. Again, if you look at the unstable, this pain is increasing in intensity and it's getting worse, okay? Now, let's keep going. So this is your normal artery, coronary artery, normal right here. Right here, now you have some kind of atherosclerotic plaque within the artery, okay, but there's still some flow going on. You know, this is your typical intermittent claudication where the oxygen demand, okay, you know, is high, but the supply is not that much, but it's still enough blood going to that area, and they're having chest pain. So that's just stable angina, also intermittent claudication for the lower extremity, okay? Unstable, now you have, you know, some kind of plaque on top of that, you are bleeding, but there's still some kind of flow. People with unstable angina usually most of the time end up getting MI, okay? But the main thing I want you to know is stable angina, you have good flow, only with activity, okay? Unstable, you have chest pain, even at rest. That's the main thing I want you to know. So there's something called MI, okay? And MI is divided into two. You have something called ST, okay, elevation MI, okay, or non-ST elevation MI, okay? They call it NSTEMI, right here, NSTEMI and STEMI, okay? So ST elevation meaning that on the EKG, you have an elevated ST segment. That's what that means, right? Whereby on the NSTEMI, non-STEMI, you have normal SC. There's no SC elevation, okay? The only way to diagnose a patient that is having MI, whether stable, whether STEMI or NSTEMI, is to get a cardiac enzyme. When you have a positive cardiac enzyme, your troponin, your CKMB, you know, that means that you have MI. Which MI do you have? You have to get an EKG to differentiate between them, okay? If the EKG shows ST elevation, then that means you are having ST elevation MI. If the EKG shows, inverse or decreased ST elevation, ST depression or normal ST, then you are dealing with a patient with NSTEMI or non-ST elevation MI. Okay, so that's the most important thing there. So now to put it together, when you have stable angina, remember with stable angina is only with activity, chest pain with activity. When it comes to unstable, you have chest pain even at rest. But the most important thing is that the cardiac enzyme is normal. Once the cardiac enzyme is positive, that means you have either STMI or non-STMI. And you got to just find out exactly what's going on with the EKG, kind of differentiate between them. Okay. And that's it. The last I want to talk about here is your MI. How do you know you have an MI? Where you have intense substernal pressure reading to the left neck, reading to the neck, to the jaw, to the back. Okay. If you remember, when you have chest pain that's reading to the back, you have your acute pericarditis, you have the esophageal rupture. Okay. And also MI is also another one that you could also have pain going to the back. But the most important thing is that you're gonna have that pain in that epigastric area. Okay. Now you remember with stable angina and unstable angina, you could give them nitrogen to feel better. With MI, sometimes doesn't respond to it. Okay. So what we want you to know for Thursday, is to be able to come up with a diagnosis. If we give you a patient and we're telling you this patient has substernal pressure in the epigastric area, pain is reading into the left jaw, feels like a big pressure on their chest, they're diaphoretic. So we're talking about MI. Okay, if you say a patient is having a chest pain with an activity, that's stable angina. If a patient is having pain that's increasing and getting worse, okay, even at rest, that's your unstable, right? If a patient has a positive EKG, okay, with the ST elevation and a positive cardiac enzyme, then you're talking about your ST elevation MI, okay? If a patient has a normal ST or a depressed ST, okay, but the cardiac enzyme is positive, that's your NSTEMI, okay, MI. All right, I won't go into depth about that. Okay, and that's it. Any questions about that? Did I lose you guys?
No.
Okay, excellent.
Dr. Sam, sorry, I couldn't find
Yes.
unmute. I was just curious, the NSTEMI and the STEMI, is there any difference in severity of those two, or it's just a EKG reading that differentiates them and they're both equally bad MIs?
Okay, so that's a great question. So if you think about this, especially for people in medicine that knows about PAD, in your PAD, think of this as stable angina, intermyocardication. Unstable angina, think of it as critical limb ischemia. Once you get MI, that means you have an occlusion. Okay, you have an occlusion of the vessel. Okay, it could be with the ST elevation or without the ST elevation. Okay, that's your acute limb ischemia, these two right here. Okay, what exactly is going on with the ST, non-ST MI, the NSTEMI? Basically the level of damage to the myocardium, okay, is not as bad as patient with ST elevation MI. Okay, so NSTEMI destruction on the myocardium is not as bad as compared to these people with ST elevation. That's the difference. Okay, so just kind of reinforce it. This right here, normal EKG. This right here, normal EKG. These two right here, you need to have a positive cardiac enzyme, okay? And this right here, you're gonna have an ST elevation, and this right here, you're just gonna have your ST depression on normal. Okay. Any other questions? Are we good? Talk to me. Are we good? Good. Excellent. So acute pericarditis, real quick. Again, don't forget, always happening after a viral infection. But look at this, pain going to the back. Now we have, I think, 4. We have MI, right? We have MI, we have acute pericarditis, right? What else? Esophageal rupture, right? Right? So just remember that, that's the things I want you guys to learn about this. Let me keep going. I'll skip that. We don't need to know that. That's for internal medicine. Okay, good. The next thing I want to talk about is aortic dissection. Listen to me. There was a study that was done, and they said anytime a patient presents with tearing, ripping pain, 99.7% of the time is aortic dissection. So guess what? On your exam, on your board exam, when you see tearing, ripping, what are you thinking now?
Aortic
Aortic
dissection.
dissection.
Aortic dissection.
Okay, I didn't make this up. This is literally, a research that was done. But anyway, so when it comes to aortic dissection, what exactly is that? So let me explain what it is. So basically, as you know, we have that tunica intima, tunica media, and tunica adventitia. So basically, what happens is you have a tear within the tunica intima, and that tear causes a bleeding, okay, in between your adventitia and basically your in between the adventitia media and also the intima. And as this bleeding grows and grows and grows and grows, your aortic dissection could lead to aortic aneurysm. As you can see here, this is the lumen, the tunica intima. There's a rupture here that's happening, a rupture. Let's just say there's a tear here that's happening within the intima, and then there's blood going into the media and the but the adventitia becomes a little thin and thin and thin and thin and thin, and we'll get to the point that it's going to rupture. So basically, aortic dissection could lead to aortic aneurysm, and that could also lead to aortic rupture. Okay, so I want you guys to remember that. So what I want you to know when it comes to the exam is that what are the causes? What causes aortic dissection? Well, long-standing hypertension. Okay, anything that is considered connective tissue disease, like your Marfan's, Ehlers-Danlos syndrome. There's something called coarctation of the aorta. Okay, and usually during the 3rd trimester of pregnancy, this right here will lead you, or could lead to aortic dissection. There are 2 types that you should know about, and the reason why you have to know about them is because the treatment is different. There is ascending aortic dissection, and there's descending aortic dissection. Okay, so the ascending is called type A, and the descending is called type B. So the treatment for ascending aortic dissection, right, is surgery. Okay, now not to confuse you, there's some of these, ascending aortic dissection out in the surgery, but again, for the board exam, they don't want to confuse you, and for the exam, we don't want to confuse you. When you have ascending, the treatment is surgery. Okay, when you have type B, which is your descending, the treatment is B, beta blocker. B for beta blocker. Okay, so think about that. B, type B, needs IV beta blocker and pain medication, obviously. Okay, so it's very important. You guys should know that. Now, another thing that's very important. So clinically, we could diagnose aortic dissection by patient telling them I'm having this ripping, tearing. Perfect. But the best way to really diagnose this, the best way, okay, is to get your chest X-ray, okay, and combine that with your CTA, okay, and that would definitely give you a diagnosis. But on the chest X-ray, when you have a widened mediastinum, especially more than 8 millimeters on the AP, that is a pathognomonic diagnosis for aortic dissection. So for aortic dissection, you want to hear things like tearing, ripping, widened mediastinum. When you hear something like that, you are done. That's aortic dissection. Then the next you have to find out, am I dealing with A or B? So they'll tell you anatomically it's located on the ascending, that's A, you need surgery. On the descending, B for beta blocker, you need beta blocker. Okay. The most important thing with aortic dissection that you need to know is that with aortic dissection, there is bleeding within the intima. There is bleeding within the vessel. Okay, the last thing you want to do is to give anticoagulant. So do me a favor, never give anticoagulant to any patient that you're suspecting aortic dissection. And that's it about that. Any questions?
Nope.
I'm rushing a little bit because I want to make sure I cover a lot of stuff. I'm reading what I wrote here. So can you give me diagnosis of possible condition that could cause chest pain radiating to the back? Give me 4.
Esophageal rupture.
Yes,
Aortic
Yeah,
dissection.
that's right.
acute
Pericarditis.
Acute pericarditis, that's it.
Esophageal.
MI.
MI. So now let me give you a little stuff to help you on the exam. So now, if I tell you a patient is having pain radiating to the back, the first thing you should do on the exam is write down this diagnosis. Oh, it could be acute pericarditis. It could be MI. It could be aortic dissection. It could be esophageal rupture. Now watch this. What if I tell you, right, this patient's pain gets better with a change in position?
Pericarditis.
Pericarditis.
Right. What if I tell you this patient, right, they have tearing and ripping sensation?
Aortic dissection.
What if I tell you this patient is having chest pain radiating to the back, okay, after drinking a lot of alcohol?
Esophageal
rupture.
What if I tell you this patient is having severe chest pain radiating to the back after an endoscopy?
Esophageal rupture.
Esophageal.
Do you guys see what I'm just doing there? That's what you need to know. On the exam, you're going to see this big clinical vignette. You, oh my God, this is too much. Look for clues. Once you look for clues, I guarantee you, you're going to get it right. Okay? Excellent. So, yes, go ahead.
Question. Just so when you said chest pain radiated to the back after drinking heavily, what was, because there were 2 answers going on: esophageal rupture and acute pericarditis. I mean pancreatitis.
I love that. Thank you. I didn't know we have pancreatitis. Right. So it could be pancreatitis. Thank you. It could be pancreatitis, and also could be esophageal rupture. Right. We're going to give you more clues. If we say amylase and lipase are negative, then you know we're talking about your esophageal rupture. Make sense?
Yes, thank you.
Good. So now, guys, look at this. So if you look at this, this lung right here, okay, this is a normal lungs. It looks beautiful. This is the mediastinum right here. That's the trachea right here. It looks beautiful. That's the heart. Looks nice. And that's the aorta right here. Beautiful, right? What do you think is going on here?
Aortic dissection.
Oh, somebody got it right. Did you see what you just did there? Beautiful. Thank you so much. Case closed. I love it. I love it. I'm going to keep going. Let me see who's going to get this right. Let me see who's going to get this one right. Look at this area.
Can you just go back to the previous slide? All right, that's fine. Thank you.
Let me see who's going to get this one right. Look at this area right here compared to this area. What do you guys notice? By the way, is it the right or the left? What do you guys think? This area.
That's right.
Okay.
Right.
That's right and that's left. Got it. Look at the right lung compared to the left lung. What do you think is going on with the right lung?
It's pneumothorax.
Oh, what got that right? What's your name? Tell me your name.
Nikolai.
Oh, Nikolai, my favorite. Well, it's not nothing. I didn't say that. I don't have any favorite, Everybody's my favorite. Good job, Nikolai. I get so excited sometimes when we teach students and they just become better than you. It just makes me so happy. I get so excited. Anyway, Nikolai, you're right. So if you guys look at this right here, you could see, if you look at this mediastinum right here, look at this right here, the trachea. What do you think is going on? Normal or abnormal?
Abnormal. So
Abnormal.
point
Is
to
it going to the
attention
right or is it going to the
pneumothorax.
left?
It's going to the
Yeah.
left.
Right. What do you call that now, Nikolai?
It's tension pneumothorax.
Yes. Tension pneumothorax is when you have so much air or fluid or anything that is pushing that mediastinum somewhere, okay, to the right, to the left, whatever, that's when you have tension pneumothorax. When you just have pneumothorax, that just means that you have air, within the lungs. And when you have air within the lungs, you're going to see, this area of dark field. That's what it's going to look like, okay? Excellent. Beautiful, beautiful. Okay, let's keep going. Let's not waste time. What is this one? Abdominal aorta, abdominal aneurysm. I don't think she covered this, right?
Yes, it's in her lecture.
Okay, good. Okay. So I'll just go over this real quick. So I just talked about abdominal aorta. Okay. Basically, aortic aneurysm, something is tearing within the intima, causing bleeding. And basically, you have the abdominal aneurysm. And clinically, what you're going to see this thing called the Gray Turner syndrome or Cullen sign, and we'll talk about that in EMED. But what I want you to know with abdominal aneurysm, you're going to get this feeling. Your belly's going to feel hard. You're going to feel a little pain in your abdominal area. Sometimes they have no pain at all. But unfortunately, is that this thing could rupture. And if it does rupture, there are 3 triad of ruptured abdominal aortic aneurysm. The number 1 is abdominal pain. Number 2 is hypotension, because they're losing so much blood, so they're going to be hypotensive. Okay, then you're going to get this palpable pulsatile mass. So those are your triad for abdominal aortic aneurysm. Okay, and basically, what is really causing aortic dissection? Right here, boom, right here. Could also be the same thing causing your abdominal aneurysm, abdominal aortic aneurysm, same thing. Okay. Any questions? Are we good?
You.
If you have a patient that's got a chest pain, what's the first thing you have to do?
EKG.
That's right. That's right. Good job. We talked about this already. Don't forget, when you have chicken pox, varicella, the virus is your human papillomavirus 3. Okay. If you have HHV 8, what is that one?
Kaposi's.
Kaposi's. That's right. Kaposi's. Anyway, good job. Let's keep that. Patient having chest pain relieved by H2 blocker or PPI. Your diagnosis is?
GERD.
That's
Good.
right. That's right. Let's keep this. I'll get you guys later on EMED. Let's keep going. What's this one? There you go. Esophageal rupture. Okay. There is something called Miller-Weiss tear, and there's something called the Boehm syndrome. What exactly is that? When you have a partial tear of the esophagus, it's called the Miller-Weiss tear, partial tear, right? But when you have a complete tear, okay, of the esophagus, that's called a Boehm syndrome, okay? And both of them will give the same symptoms: shooting pain, chest pain, going to the back, okay, after drinking, after iatrogenic caused by endoscopy or some kind of a procedure, okay? So if you look right here, right, you can see that you don't see any lucencies, okay, by the side of the mediastinum. Everything looks beautiful, look nice. But if you look right here, you could see this lucency. And that lucency you're seeing is the air, okay, the air within the esophagus, okay? And if you're not careful, if you have a Boehm syndrome, that air, okay, that is opened within the esophagus could go right into the lung and cause pneumothorax, okay? So esophageal rupture could lead to pneumothorax. Again, being shown here, you could see that you see that lucency right here, area of opacity and area of lucency. So anytime you see, let me go back, anytime you see area of opacity, right, on the outside and the inner border, but on the inside of it, you see that lucency. So outside opacity. Inside, in the middle, you have lucency. That is your pathognomonic diagnosis for esophageal rupture. Again, look right here. You see area of opacity, and in the middle, you see that lucency, pathognomonic for your esophageal rupture. Okay. Again, look right here. That lucency right here, opacity right there. That's the air. Okay. When you see that, that is your esophageal rupture. Okay. We keep going. I have a lot to cover. Pancreatitis, we discussed that already. DVT. Okay. So let me make sure I covered everything. Hold on, give me one. Just make sure I cover everything with the. If I go to DVT, let me go to my question bank, which is all the way in the bottom, right here. Well, good. So MI, squeezing pain, tightness, heaviness, epigastric area. That's your MI, right? Chest pain reading into the back, your aortic dissection, esophageal rupture, acute pancreatitis, acute pericarditis, MI, right? Chest pain resolves with positional change, acute pancreatitis, okay? And your acute pericarditis, okay? So when you see tearing, ripping, aortic dissection, vomiting, retching, when you hear the word retching, it's like, you're vomiting aggressively, from alcohol use, that's your esophageal rupture. Again, we talked about this, we talked about that, and I said, okay. What am I doing here? Retching. So when you hear the word retching, vomiting, that's your esophageal rupture. Okay. Any question about chest pain? That's it for chest pain. Are we good?
Yep.
I hope I did an okay job. Did I do an okay job here?
Indeed.
Okay, just make sure I
You're
cover that.
doing great, Dr. Sam.
I just want to tell you, I'm not a medical doctor, so don't be like, this guy's acting like a medical doctor. I'm not. So anyway, let's go to the next one. I think, next one is DVT. DVT, basically from the word deep venous thrombosis, that means you have a clot, right, in a deep vein. You have a superficial vein, your varicosities, and you have the perforating vein. For people in medicine, what is the confluence?
Where veins come together.
So when you have your small saphenous vein, where does that drain into?
Popliteal vein.
What about your great saphenous?
Femoral vein.
That's right. Good. Excellent. Okay. Bartol triad. I have a mnemonic. My mnemonic is HIV. The H is your hypercoagulability. Your I is your endothelial injury. And your V is your what's my last one?
Venous.
Venous stasis. Okay. So when it comes to your blood clot,
we can't see your screen.
oh geez, really? I'm so sorry. I apologize. So you haven't been seeing my screen all this while?
No,
it's 5 minutes.
We were, but you didn't show it once you started looking at your questions.
Okay, got it. Okay, good. Okay. Can you see it now?
Yep.
yes.
Good.
Yep.
So when you hear things like, patients having swollen, painful leg, is unilateral, edematous, warm, painful, right? You should start thinking of multiple differential diagnosis, cellulitis or fracture, whatever. But when they give you clues like, patient has been sitting for a long time, they travel from Africa to the United States, or patient is pregnant, or patient has cancer. So things like that should kind of push you towards maybe this patient has DVT, but you should know your virtual triad. Okay, you should know that hypercoagulability, your endothelial injury, and also your venous stasis. Okay, now this will always get you guys on the exam. I don't know why it's a problem. It's always going to get you guys. But anyway, so homing test or homing sign and price sign, you need to know the diagnosis. I mean, the definition, sorry, definition. Okay. A Pratt sign is pretty much when you squeeze or compress, okay, the calf muscle. Okay. And my mnemonic that I use is PC. Pratt, right, compresses calf muscle. I don't know, stupid, but I don't know if that would help somebody. PC, like your PC, you have like your computer, PC, all right? And your omen is pretty much when you dorsiflex the foot, and that's causing pain to the leg, okay? So you should know that. Now, the most important thing I want to tell you guys is studies have proven, have shown this, that omen and price sign are useless. Trust me. A patient could be having blood clot, and your omen and Pratt test could be negative. And a patient could have a negative blood clot, and they could have a positive omen and Pratt. So omen and Pratt are not sensitive, and they're not specific. But guess what? On the board exam, they still test you on it. So if you're hearing things like a patient present with acutely swelling, your lateral leg, very painful to touch, they have a positive omen, they have a positive Pratt, they're trying to push you towards DVT. Any questions? Okay. There is something called D-dimers. D-dimer is a blood test that you could do to rule out DVT. Okay. So if your D-dimer, okay, is negative, is 0, negative, okay, your chances of having DVT is 0. Now, I'm not going to say 0 because it's super weird. It's very low. It's very low. So when your D-dimer is negative, your chance of having DVT is kind of low. But if your D-dimer is positive, your diagnosis could be anything. It could be because you're pregnant. It could be because you have MI. It could be because you have trauma. It could be anything. It could be DVT. Okay. So when D-dimer is positive, it's non-specific. It's very sensitive, but it's non-specific. So I want to make sure you guys understand that. So on the exam, don't be thinking D-dimer is the best test to rule out DVT. But actually, ruling DVT, I don't know what we'll call it, ruling. But D-dimer is no good at all, especially when it's positive. But when it's negative, it's pretty good to tell you that you don't have DVT. Okay? All right. The next thing I want you guys to know are these two mnemonics. Okay? These two mnemonics are very important. The first one is I am clotted. Okay? The second one is thrombosis. My favorite, and this is where I take all my questions, thrombosis. I love it. And the board loved this one. Okay. FYI, I was part of the people that made the curriculum guide for medicine. So FYI, all the chairs in medicine, all schools, when we put this together, they love thrombosis. FYI, and I'll tell you why in a minute. Anyway, I am clotted. You should know that. Take a picture of it. You should know it. And this thrombosis. Let me tell you why I love thrombosis. On the exam, they always test this. They will say, patient has, factor 5 Leiden. That means they have an high chance of DVT. Patient has protein C and S deficiency, high chance of DVT, right? Antithrombin 3 deficiency, they have DVT. So the way they will trick you, they will say, patient has increased protein C and S, and that's it. Now, protein C and S are very important, for the upkeep and actually for the activity of heparin. Okay, so you need them, right? So basically, when you have deficiency of protein C and S, that means you're gonna clot. So please make sure you know things that could lead to your DVT, especially your factor 5 Leiden, protein C and S deficiency, antithrombin 3 deficiency. You should know that. And the rest of them is just, your malignancy, your blood polycythemia, obesity, smoking, splenectomies, and all that stuff. Okay. Any questions?
Yeah, Dr. Sam.
Go ahead.
Hi. What's the first thing you would do for a DVT? Would you do a duplex or a D-dimer?
Good, excellent. So if I'm suspecting that a patient has a blood clot, the first thing I'm doing is my venous duplex. Okay. The reason why that is because it's an emergency, right? That blood clot could end up in your lungs. So ultrasound is so fast, it's so quick. It can be done real quick down in the ER. It takes a couple of seconds and you get your result right away. So every time you are thinking of DBT, listen to me again. Don't even think about D-dimers. You're getting a venous duplex right away. Okay. But on your board exam, if they ask you, you have a patient that you're suspecting DBT, what blood tests? See, they didn't ask you what imaging studies, what blood tests will you order for this patient? That's when you're going to order your D-dimers. Okay. Well, if they just ask what tests, then you want to do your venous duplex, number one. Okay.
Thank you.
Excellent. So again, clues: positive D-dimer, positive PROTS, positive omen, positive venous duplex. You know you're dealing with DVT. Okay. I am clotted. Oh, I forgot to tell you this. You remember that Butcher's triad? Okay. The Butcher's triad is a summary of I am clotted. The Butcher's triad is a summary of thrombosis. FYI. Okay. All right. So Wells criteria, just for you guys to know, it's not gonna be in the exam, just for you guys to know, there's something called the Wells criteria for DBT, and there's Wells criteria for PE. And basically what this is saying is that if you have a very low suspicion for DBT, very low, okay, you could get your D-dimer. If the D-dimer is negative, guess what? See what it did? Discharge. Don't even get ultrasound. Don't even get nothing. You are going home, right? That's what I'm trying to tell you. If D-dimer is negative, it can never, well, I won't say never. It most of the time can be DVT, right? But if it's positive, it could be anything. And at that time, you want to order your venous duplex. If you have a high suspicion, so high, okay, is you notice what they did here? They didn't get a D-dimer. They got an ultrasound. Also, your duplex, right? Duplex ultrasound, same thing. So they got an ultrasound. Okay, if your ultrasound is negative, they say repeat it. If it's positive, then you will treat the DVT. Just remember that, please. Okay. We talked about that already. Okay, look at this ultrasound. Do we have DVT? Yes or no?
Yes.
Why?
Non-compressible.
Press.
That's right. The vessel is not compressible. That's your blood clot right here. Okay, it's hypoechoic. Okay, it's not compressible. See that? It's not compressing. If it's not compressing, that's your diagnosis for DVT. Any question? You could talk to me. Any questions? No? Yes?
Oh, but it's a cool video.
I know you like it. I did it on purpose for Jill. I know you like it, Jill. All right.
I agree with you.
Yeah. By the way, this is fun to me. I like this. This is fun. When I'm teaching, I love it. It's fun. Anyway, I apologize. I'm enjoying this, by the way. Are you guys enjoying this? I don't know if you're enjoying it. Do you guys think I'm weird or something? Like this guy's enjoying teaching. I just love it. Anyway, forget it. Forget it.
I'm spending my evening any other way, Dr. Sam.
Oh, thank you. Anyway, so when it comes to DVT, obviously, the best way to treat your DVT is to give them anticoagulant. Question for you. What cardiac disease should you never give anticoagulant?
Aortic
dissection.
Good job. Excellent. So all this, right, we'll cover in EMED. EMED is like PASS. You remember PASS course? EMED always give me tough time because there's a lot of material. It's just, I don't know. Every time I feel it in medicine, it's always EMED. Just drive me crazy. Anyway, we'll try our best to make sure you guys do well. I love this class, by the way. You guys are very smart. So we should have any problem here. I'll keep on skipping this. We'll talk about that later. Okay, PE. I need to go faster. So PE, when you're hearing things like shortness of breath, this right here, there was a study. I forgot the name of the study I was reading it. What was this? Can't remember. New England Medical Journal. When the patient is having shortness of breath, okay, and they have pleuritic chest pain with tachycardia, 1, 2, 3. I'm not gonna say 100%. I'll say 95% of the time is PE. 95% of the time. Case closed. When you see shortness of breath, tachycardia, and pleuritic pain, okay, almost 100% is your PE. So just make sure you know that. You know, these people have tachycardia, shortness of breath, and obviously they're going to have hemoptysis. Again, dyspnea, pleurisy, cough, hemoptysis, tachycardia, again, tachypnea, tachycardia. But when you combine tachycardia, pleurisy, okay, and what's my last one? And shortness of breath, it's almost 100%. Okay. Now, what I want you to know here that's very important, okay, is what are the chest X-ray findings that you see? Now, unfortunately, these chest X-ray findings are not really that sensitive, but they tested a lot on the exam, so you should know it. So a patient that's having chest pain, you might see athleticis, you might see aptin hump, you might see pleural effusion, and you might see Western mark sign. So this Western mark sign and aptin hump, these two are so, for some reason, they tested a lot on the exam. So when you see Western mark sign and a positive aptin hump, that is your pathognomatic for PE. I'll skip that. You don't have to know that for now. Forget about that. Okay.
Dr. Sam, that
Yes.
the Western sign mark or whatever it's called. I remember her speaking of that in her lecture, but are we gonna have to identify that on a chest X-ray?
Yes.
Can you are you able to remind us what that looks like, or
let me see. I don't think let me see. If it's here, I'll show you. If it's here, I'll show you. If not, I'll get it to you. The next one I want to show you real quick is EKG. This EKG pattern is not that common, okay, for your PE. But anytime, okay, you have on a lead 1 S wave, on a lead 3 Q wave, okay, on a lead 3 T wave, right? Anytime you see S1, Q3, T3, anytime you see that, that is pathognomonic for PE. It's not that sensitive, but on a board exam, yes, unfortunately, you have to know that. So let me go back again and just stress this. Western mark sign, aptin ump, okay? And your S1, come on, let's go. Your S1, Q3, T3, when you see all the signs, that's your PE right there. Okay, I think I have it here. Yeah, I do. I have it here. So Western, I think I have a better one. Okay, good. This is a better one. So guys, take a look at this. And it's very easy. All this, what you see right, are called lung markings. See these lung markings right? These are called lung markings. These are vasculature to the lungs. Okay, you're supposed to see that. If you look right here, you notice that you see a little bit of lung marking and all of a sudden just gone. You can't find it anymore. Gone. Right? You guys see this? Yes?
Yes.
So this kind of look like your pneumothorax, right? But this patient, lung markings is completely gone. You can't see lung markings. When you see that, that's what is called the Western mark sign, when the lung markings completely disappear due to a proximal embolism. So there's a clot here. There's a clot here that is making sure there's no blood flow going to the peripheral cavity. Any questions? Does that make sense?
Yes, thank you for showing that.
Okay. The next one, that's EMED. Forget it. Next one. I'm gonna show you. Okay. So aptin ump. okay, kind of look just like your atelectasis. So right here, the Apton hump is kind of like, blurry, kind of looking, again, it's not specific, kind of blurry, so it's like an opacity. It's like almost like pneumonia. If I show you this right, like, oh, this patient has pneumonia and a lower lung base. Like, oh, this patient has pleural effusion. So it's not specific, but they will tell you if you hear things like Apton hump, kind of look like this, this opacity here, that is pathognomonic for PE. Okay. And basically, when it comes to diagnosing PE, the best way to diagnose PE is to do pulmonary CTA or spiral CT. Okay, pulmonary CTA, so pulmonary CT angiography. That's the best way to diagnose it. So spiral CT. Okay, your DVT in the leg, you use venous duplex. For PE in the lungs, you use pulmonary CTA or spiral CT. We're good? Yes?
Yep.
Okay. And the best way to treat this, same thing, anticoagulant. Now, in EMED, you have to know every one of this. EMED is anyway, you have to know every one of it. But for this exam, you don't have to know all this. Just know anticoagulant. Know what heparin is. Heparin is an anticoagulant, right? So that's it. That's it. Okay. That's for part 2. Let me see. Okay, good. This one. Okay. So this is a patient but this is called pneumothorax. Pneumothorax just means air in the lungs, right? A procavity. So there's something called a spontaneous pneumothorax and something called traumatic pneumothorax. Okay, spontaneous pneumothorax is divided to primary and secondary. Okay. Basically, this is seen in like young people. They are long and thin. With the spontaneous pneumothorax, sometimes when it's not that bad, you could just monitor the patient, okay, and just let it be. But when it becomes your tension pneumothorax, you got to do an decompression. Now, sometimes your pneumothorax by itself might be so bad that you might need decompression. So anytime you're suspecting, pneumothorax, especially tension pneumothorax, the first you want to do is need decompression, check X-ray, then EKG. That's a reverse. Okay. And again, pneumothorax, young, tall, thin, pleuritic chest pain, Anyway, I go right here. Beautiful example. Look at this right here. Look at just that area of hyperdensity here. No, that's hyperdensity. Radiolucency. Huge area of radiolucency due to a massive air. Okay. And you could see that the mediastinum and the trachea is being pushed right to the left side. This is a pathognomonic for your tension pneumothorax. And this patient right here, if you do EKG, they are dead. You got to put a needle in there and decompress it. Okay? Okay, next one. Costochondritis, very simple. Costochondritis is chest pain, basically within the ribs. Okay? And basically, this is really common in people that are younger, people that lift weights, and they have chest pain. Okay? So this chest pain, the way you differentiate this chest pain from MI is you want to do EKG. EKG is going to be negative. Cardiac enzyme is going to be negative. Another best way to diagnose this condition is when you touch the area. Just, oh, it hurts, it hurts. And most of the time, it's not just one site, it's like multiple sites. Okay. So when you touch them, okay, they say, oh my God, it hurts right there. They'll tell you exactly where it's hurting. And it's not really radiating anywhere most of the time. It's not really moving up most of the time. It could radiate, but most of it's not really radiating. When you touch the chest, it will hurt. Okay? That's your costochondritis. You're kind of seeing in younger people. Okay? There's no swelling, there's no nothing. You give them pain medication, anti-inflammatory, they do well. They're fine. Okay? Okay, let me keep going. Make sure I cover everything. There's a question here. Let me try this one. Oh, that's one. Okay. Does anyone want to try this one right here? This patient is a smoker, a male with a pulsatile mass?
Abdominal aortic aneurysm.
Beautiful. How about this one? Exertional. Exertional, that means after activity. Exertional. Epigastric pain. Improve with rest.
Stable angina.
Oh, look at that. Look at that. Stable angina is similar to what condition in the lower extremity?
Intermittent claudication.
That's right. That's right. That's right. Okay, good job. Okay. Let me go to the next one. Let me go to the next one. Okay. So the next one is this right here. Okay. I guarantee you there's a question on the exam that's going to get you. You'll be surprised. You'll see. Unfortunately, this question, I try to take it out, but of course the rest was like, yo, you're going to leave it. Leave it. I want them to think. Not for sure. For me, I like to give questions that you could apply. Question you could apply on a clinical basis. I hate questions like just going to memorize and dump it. Just drive me nuts. Anyway, that said, apologize. So you have to do your disaster medicine. What's there. For example, what's happening in Israel, right? So there's a disaster going on. You're going to respond to the disaster. Okay, after responding to the disaster, you're going to go for recovery, count your losses and go for recovery. And what is mitigation?
You prepare beforehand, basically, like you try to prevent it.
Exactly. And then you do your preparation. What I need you to know examples of response, recovery, mitigation, and preparation, definitions of all of this. That's what you have to know. I can't teach you that. You just got to study. Okay. Oh, there's a question on the exam. They will give you scenarios and they will say, which one will you say first? The trick to that is, if I give you two patients, patient 1 and patient 2. Patient 1 is a 5-year-old that is crushed, okay, after a bomb in Israel, completely crushed, okay, and lifeless. 5-year-old. And you have patient 2 who is 79 and has got a bleeder in the ankle. Which one will you say first?
Patient 1.
Child.
The second patient.
Let me
Is
repeat.
patient 1 dead?
Let me repeat.
Let me repeat.
You have a patient, right? Patient 1, 5-year-old, crushed on a crumbled building, okay, and lifeless. And patient 2, 79, a bleed on the ankle.
When you say life,
Does he have a chance to
they're
save him?
dead already?
Is patient 1 dead?
I don't know.
When you
So
say
that's
bleeding at the ankle, do
patient-
you mean just any kind of bleeding?
Arterial bleed.
You gotta save the second one.
When I say someone is lifeless, what does that mean?
They appear dead.
No life.
Exactly, no life. Even though the patient is very young, but they have no life. Why do you want to save that? Gotta go to the next one. Does that make sense? It's very painful. It hurts. But again, if the patient is lifeless, you gotta go to the next one that you could save. Okay? What about a patient that is having anaphylactic reaction, anaphylaxis, right? Anaphylactic reaction. This patient has an EpiPen on the end. There's another patient that is also having anaphylactic reaction, and this patient has stridor. Which one will you say first?
The second one with Strider,
Why?
because they don't have an EpiPen and they have Strider.
That's it. That's what you got to think. So there are questions on the exam that will give you a scenario in a disaster. Which one will you say first? So you just got to think about it and calm down, and think about it. Okay. All right. Next one, local anesthesia. Should I stop? I mean, I have a lot to cover. Are you guys okay? You guys tired?
You can keep going.
I'm never
Have as
tired.
much energy as you.
Say it again.
We have as much energy as you. Don't worry. Until you're finished, we're not finished.
Listen, I'm enjoying it. So I don't know about you, but this is fun. This is good. I like it. Anyway, look at anesthetic. You need to know your dosing. Okay. You need to know your dosing. I would highly recommend take a picture of the slide. Know your dosing. They ask this question all the time, everywhere, board interviews, residency interviews, board questions, and whatnot. Know this very well. Okay. All right. When you have lidocaine, right, there's something called the max dose, and there's something called the absolute recommended dose. The absolute recommended dose is for 70 kg people. Okay, 70 kg. But your max dose, so the FDA say, this is what is really safe on a patient that is, normal weight, 70 kg and below. Okay. So let's say you have a patient that is, they can't talk and they're not responsive. You could use a lidocaine on that patient. Hey, this the max dose I could give this patient is this and that. But if you know their weight, then what you have to do is just multiply, that 4.5 or 7 or 2.5 by their weight, and that's it. So max dose is the maximum dose you give that patient. Absolute dose is what's recommended by FDA for 70 kilo patient. Okay. So for lidocaine, the max dose is 4.5 milligrams per kg. With epinephrine is 7 milligrams per kg. Bupivacaine max dose is 2.5 without epi. With epi is 3 milligrams. I just don't know how I'm going to teach you this. You just got to know it. Got to memorize this, right? That's very important. The next thing is a little bit of calculation on the exam. A little bit of calculation, not bad. 1% lidocaine equals 10 milligrams per ml. All what you have to do, when you see 1% anything, 2% something, just multiply by 10. Like this one, lidocaine 2%, multiply it by 10. That's going to give it 20 milligrams per ml. And that's it. Okay. And now you can now say, 1 ml of this lidocaine 2% is equal to 20 milligrams. Then you could do your calculation from that. Does that make sense?
Yep.
Good.
Dr.
Okay.
Sam,
Yes.
if we're required to do, like, I know we had to do one of these in farm. So, is it going to be with the person's weight, and we have to figure out what the maximum amount is that they can be given?
Yep.
That setting. So
Yep.
will it be given in pounds, or are they going to give it to us in kilograms? Do we need to know how to do that conversion?
Kilograms.
Okay, thank you.
I'm going to give you in kilograms, just multiply, just multiply, just multiply. That's it. Or we will give you, a patient presents with a laceration and we wanted to give 1% lidocaine. How many milligram per ml is that? Just multiply by 10, and that's it. Okay, all right. So when you say, again, absolutes, that means for lidocaine, the max dose for 70 kg is 300 without epi, is 500 with epi. Okay, for 70 kilo person with bupivacaine, marking, is 175 with that epi, and with epi is 225. I don't know how to teach you this. You just got to memorize, got to know it. Okay.
I have a question about that. What if the max dose per individual that you calculate is hypothetically comes out above the absolute recommended max? Can you go above the absolute recommended max?
Yes, absolutely.
Okay.
As long as you know the kilo of that patient. But if you do not know the kilo of that patient, you got to stay with the FDA recommended 70 kilo.
So what about vice versa? What if I knew the kilos and I calculated it and it said their max was 200? Can I still give them 300 since that's the absolute max?
Right. But again, that's what's being asked. Yes, absolutely.
Okay, thanks.
Okay. Okay, what is the maximum dose of marking without epi for a 70 kg patient? Anyone?
175.
You see that? You just got to memorize it. What is the absolute max dose?
175.
Right, because I didn't give you the kg, but once I give you the kg, then you got to just multiply it with whatever we're going to give you. Okay, what about this? A patient, you have a 20 cc's of 1% lidocaine plain. Okay, how many milligrams is that?
20.
200.
That's right. Okay. Okay, just know that calculation. That's it. Take a picture of this. That's your spare time tomorrow. Calculate it, learn it, understand it. We do? We're good?
Yep.
Okay.
Fabulous.
All right. I'm just rushing because I want you guys to go and sleep. So I'm trying to finish this. I have a lot of stuff to cover. Okay. Anesthesia. Be careful with epi. Why am I saying this? Oh, okay. So basically, there's something called end organs, like your fingers, the toes, tip of the nose, ear, penis. You know, epinephrine is a vasoconstrictor. And basically what happens when you mix epinephrine with your lidocaine, what's going to happen is that you're going to cause vasoconstriction. And if you put it into end organs, it could lead to ischemic toe. Now, if a patient has got a good pulses, again, I've done it multiple times where I've given epinephrine to the foot and nothing happens. But again, you have to be extremely careful. That's what they're trying to say here. Okay, epinephrine will cause vasoconstriction. Any questions? Does it make sense? Fingers, toes, tips of the nose. Again, for the exam and for the board exam, okay, you want to try to stay away from this area. Okay, when you come to epinephrine, stay away from giving epinephrine in the fingers and the toes, tip of the nose, ear, and penis. Okay, we're good?
Yep.
Okay.
Good.
The next one I want to talk about is your EMED and your ester. Okay. So your ester, basically, the best way to differentiate between EMED and ester is how many eyes that you see, okay, in the genetic name. So, for example, the genetic name for this ester protein is protein, right? And this one is lidocaine. Okay. So protein, if you look at protein, how many eyes do you see in protein? Right? You see only one, right? So if you see only one, that's an ester. On the genetic name, lidocaine, on a lidocaine, you have two eyes. So when you have two eyes, okay, that's your amide. Does that make sense?
Yep.
Okay. Another thing that's very important is that your ester is metabolized by your blood, by this enzyme called plasma pseudocholinesterase. Okay, that's the enzyme that's breaking down your ester, whereby your amide is broken down by the liver, right? The biggest problem is that when the ester is broken down, okay, you are converting, the metabolite to PABA. Does anybody know what a PABA is?
Is it like para-amino-benzoic acid?
Yeah.
Para-amino-benzoic. Yeah, that's right. That's what it is. What's the number one problem with this chemical?
Allergic cross reaction.
Allergic contact dermatitis. Okay, so para-amino-benzoic acid, PABA, okay, is one of the metabolites after you break down ester. And if you have a patient that's got allergic reaction to PABA, or they're allergic or they're sensitive to PABA, you want to make sure you don't give them any ester. If you do, they're going to break down, okay, into hives, your urticaria, okay. So anyway, so if you look at this brand name, this generic name, benzocaine, only one eye, procaine, one eye, tetracaine, one eye, propoxycaine, one eye. So that's your ester. Make sense? So most of the time, your local anesthetics, they are vasodilators. Okay. Now, there is one ester in the old time that is used as anesthetic, but now people are using it as recreational drug, and they're enjoying themselves with it. What's the name of that, Esther?
Okay.
Cocaine.
Cocaine. Cocaine, unfortunately, is a vasoconstrictor. Okay, whereby most of your anesthetic agents are pretty much vasodilators. Okay, most of them. Your cocaine is a vasoconstrictor, a strong one at it. Okay. Okay, I need a volunteer. What anesthesia is best in patient with liver disease? Esters. What anesthesia is best in patient with PABA? Exactly. So you guys see that? Okay, I don't want to get you. I want you to make sure you guys understand this concept. Okay, good job. How do you increase the duration of an anesthesia?
Add epi.
Add epi. That's it. Good job. What happened here? Stuff. Okay, let's keep going. Okay. So I am done with that. So the next I want to talk about is wounds, right? When it comes to wounds, you want to know if the wound is sore, is clean. Okay, if it's sore, you have to debris, you have to clean it, you have to flush it out with disinfectants, use betadine, chlorhexidine. If it's open fracture versus closed, is open fracture an emergency or not an emergency?
Emergency.
Exactly, emergency. So this right here, you got to put them on IV antibiotics right away. So it depends what kind of wound you're dealing with. Another thing is the patient healthy or immunocompromised? If the patient is healthy and the patient is healthy, okay, and they have mild infection, you want to give them a staph coverage, staph aureus coverage. If patient is immunocompromised, again, they have mild infection, you want to cover staph. But if the patient is healthy and they have moderate to severe infection, you give them staph coverage. Now watch this. If the patient is immunocompromised and they have moderate to severe infection, you want to cover polymicrobial. Does that make sense? Any questions? Good. So we're good. The next one is when you have wound that is bleeding, right? You wanted to do a little bit of hemostasis. So when it comes to hemostasis, these are the things you could use: mechanical, thermal, chemical, or topical. Mechanical, just putting pressure, okay, or just using a tourniquet. That's a mechanical. So anytime you have a bleeding, the first thing you do, you put pressure on it. That's number one, okay? Followed by, so that's number one, okay? The next thing you could do a little bit of chemical also, where you mix a little bit of lidocaine with epi. That will also reduce your hemostasis for you because of vasoconstriction, right? And you could do a topical. A topical you could use here is your lumicaine, something called lumicaine, that could be used to. Lumicaine is like a chemical hemostasis they could apply to stop bleeding. Tomo is, have you guys been to the OR? You see this electrocautery? You guys seen that before? Electrocautery?
Yes.
You know? Okay. That's your tomo. You could use that also in the ER. They have and I've done it before, when I was in residency, where they have this handheld electrocautery, okay, and you just activate it and just place it, on the bleeder, and it will start the bleeding. Unfortunately, it's very, very painful. Okay. So again, mechanical, direct pressure, thermal, electrocautery, right? And your topicals, topical thrombin is another one. Okay. And whatever. When it comes to types of debridement, when you have a wound, you could use a mechanical debridement using water to flush it out as mechanical debridement, or using a gauze to clean it out as mechanical debridement. Sharp debridement using a blade. Enzymatic. Okay, give me an example of enzymatic. Anyone?
Santal.
Or collagenase, right? Biologic, using a maggot. Autolytic, using the body to pretty much debride itself. Okay, Next thing is irrigation. When you have a wound that is dirty, you want to irrigate it. When that one is soiled, okay, the last thing you want to do is to have a high pressured, flush. You don't want that. High pressure flush will just push that dirt even deeper. So your porcelain bark is a very high pressured, irrigating material that you don't want to use when the wound is really, really sore. When the wound is really sore, you want to use something called cystotubing, and it's better, right? Cystotubing or Bob syringe. So basically, what you're just using is just a little bit of water that's dripping down and using it to kind of flush and clean the wound. The last thing you want to do is to put a heavy duty pressure to push that soil wound in. But you can use all these things to flush a wound. Any questions so far? Okay, let's do some play. I need a volunteer. So in a minute. So when it comes to closure, you could use suture to close the wound. You could use steri strips, also called adhesive tapes, to close the wound. You could use a tissue adhesive or chemical suture, example, double bond, to close the wound. Or you could use staple, right? When you have high tension area, what does that mean? High tension wound.
High risk of dehiscence.
Right. That means to put it together is so hard to put them together. It's like so much tension. So when we have a high tension wound, which out of these four can you use for high tension wound?
Sutures.
Suture is your number one. That's it. That's your number one. It's the best one, right? Followed by staple. Never use steri strips or chemical suture for high tension wounds. Okay. Okay. Now I need a volunteer. Okay. Which one gives you the best and greatest tensile strength?
Sutures.
Oh, you've been studying. Who's that? Is that Nikolai again?
No.
Who's that?
John Kashani.
John? Is it John?
Yes.
Oh, I don't know John. Oh, I want to see John.
Nice to meet you.
I haven't seen John. I can see a picture. Where's John? Are you in surgery or medicine?
I'm in surgery.
Surgery. That's coming to me later, so I get to know you. You can't escape me. I get to know you. What's my friend? Where's Caroline? Caroline's not here today. Oh, Caroline's in trouble. Oh, I know Tilla can't be here.
I'm here.
Tilla Furtado is here?
I'm here. It's Caroline. We're both here.
Tilla. Is that
We're
Caroline?
both here. We're both here.
I don't see anybody here. Okay, okay, good. All right. So, lowest wound dehiscence. Lowest wound dehiscence.
Staples. I'm sorry, sutures.
Anybody else?
Sutures.
Sutures.
Somebody say staples.
That was a mistake. I meant to say sutures.
Good. Basically, if you have a very high tensile strength, also you're going to have the lowest wound dehiscence, okay? How about this one? It cannot be used on the hairy parts.
Tissue adhesive.
Sutures.
And steri strips.
Steri strips. Yeah. Absolutely. Good. The least reactive.
Sutures. Oh, wait, no, they have the highest. They're the highest.
Staples. Adhesive tapes.
Wait. Dr. Sam, I got a quick question.
Yeah.
So why do they usually staple like a head wound, like a serious head wound?
The reason why is because it's faster, okay, and also it gives you what's what I'm looking for. It's faster, and also the tensile strength is kind of close to suture. So that's the reason why. All right. You want to close it as soon as possible. Now, the reason why we don't really care about using a staple on the scalp is because air is going to grow on it and it's going to be covered. So we don't care. So just faster. Another reason why you don't want to use suture on the head or suture on the scalp is because you could cause something called epidermal inclusion cyst. Okay, that's remember there's air over there. So no matter how you shave it and you're trying to suture that, you could imaginate tissue deeper into subacute layer, and that could cause epidermal occlusion cyst. So that's what you use staple.
Thank you.
Good. Okay, mostly used on the face.
Tissue adhesive.
That's right, dermabond or tissue adhesive. Good. Resistant to bacterial growth.
Tissue adhesive.
Low tissue reactivity.
Adhesive tape.
Staples.
Staples. I better go study. Less meticulous closure versus the best meticulous closure. So 2 answers.
Staples.
And what's the
Fastest sutures.
exactly? So these are kind of question you're gonna get on the exam. Okay, so just make sure you're ready for it. Okay, this is just examples of your tissue adhesives. Let me show you. Yeah, see, dermabond is right here. Dermabond, liquid band. I use liquid band a lot. One of my favorites is liquid band. I don't know why it's really, really good. I can't find it here. CryoSeal is amazing. I love CryoSeal. Okay. Anyway, that just, whatever that people use. Whatever you go to the hospital, they will show you which one they have. Just call it, I need some tissue adhesive. They'll give you whatever they have. Okay. Okay. Now, question?
Yeah, would it be okay if you go back to that one slide with all the questions? If it's okay, if we take a picture. Thank you.
Yeah, listen, this is for you. Take pictures. I don't care. You have to
Thank you.
remember, I want you guys to do well. My job is to make sure everybody get 100. But you got to show that you know the material. That's all. Show that you've studied. We're good?
Yeah, thank you so much.
Okay. I'm going to call names now. West Taylor Furtado. Hi, Taylor.
Hi.
So, Taylor, look at this wound right here, right? Do you think it's so easy for me to close this wound? What do you think? With a dermal bond?
No, because it's not well approximated to edges.
Right. This is what they call high tension wound. I need to push it. So what do you think I could use here?
Probably sutures.
Got it. Sutures number 1. I mean, I could also push for a little bit of staple if I want to, but the number 1 is suture. Excellent. Okay, AJ. Let me pick on you a little bit. Hey, look at this right here, right? What do you think you could use here? This patient comes to you in the clinic, By the way, this is a joint. It's a joint. It's a joint here. It's a joint. It's a joint. Joint. That's a clue. Joint.
Okay.
So, what will you use here for this patient? Joint.
I would use sutures if it's high tension.
Can I use dermabond?
No, it'll break apart
Why?
because it's a high tension area. If it's over a joint, it'll dehisce.
Right. That's right. Suture or staples fine. Preferably, I'll do suture on this one. Suture is number 1 here also because over the joint. Okay. Tissue adhesive, forget it. Not going to work.
Okay.
Right here. Okay. If you look at this right here, the indication for tissue adhesives and adhesive tapes is kind of similar. The wound has to be well approximated, really, really well approximated. Then you could use your stero strips, or like this one, you can use dermabond, right? Again, with this one, stay away from area. And with this one right here, tissue adhesive is good for faces, right? Okay, what about this one? What can I use here, AJ?
I mean, it's not well approximated, and sutures probably. I mean, I would use sutures.
Can I use suture here?
You can try. It's the skin's torn.
You in medicine right now. What's your diagnosis?
That's a skin tear.
Oh, beautiful. What stage? Let me see. When you get my question right, I
Stage
keep
3.
going higher. Oh, you got it too?
Stage 3. There's no skin at all. It's completely torn.
Exactly. There's no skin. We can't reapproximate this. This is state 3 skin tear. So what can I use for this beautiful baby here?
I mean, you're gonna have to use sutures because you're gonna have to. It's gonna be high tension if you're gonna pull the skin, or you can use maybe that tissue adhesive stuff, maybe, or
Let it
I
heal
don't know.
secondary intention.
Who said that? Who's that? Who's that?
That's Cindy.
Who's Cindy? Oh, I gotta know Cindy. Who's Cindy? Is that my Egyptian lady? Is Cindy Egyptian?
No.
Palestinian. I can't remember where you from. Where you from again?
I'm from Iraq.
Iraq. That's Cindy. You in surgery, right?
I'm in surgery, yes.
Oh, I remember you, Cindy. Yes. I remember you in whatchamacallit.
Metro. Oh, at Harlem. We met at Harlem.
Oh, I know.
Yeah.
Clinical skills. Yes, clinical skills. I
Yes,
remember you
yes, that's
were
me.
answering all my questions.
Yeah,
Yes, I
yes,
remember.
that's me.
You're 100% correct, Cindy. Healing by secondary intention. Well, I think, I just penalized, so I apologize. I can't close this. It's too superficial. There's nothing to reapproximate. Secondary intention. I could use a wet, moist on there. I could use a collagen on there. I could use, either colloid if I want to. Just secondary intention here. Make sense? Yes, we're good? All right. Okay, Cindy, since you're here. Cindy, if I wanted to remove the suture to the dorsum of the foot, how long should I keep that suture?
Usually keep them 3 to 4 weeks. No?
Dorsum of the foot, dorsum. Anybody else?
2 to 3 weeks.
14 days.
14 days, 10 to 14 days. 10 to 14 days. You guys see this all the time. Post-op. Your post-op is 10 to 14 days. Don't forget that. Dorsum of the foot. What about the bottom of the foot?
3 weeks.
That's right, 3 weeks. What about the scalp?
7 to 10 days.
10 days.
7 to 10 days. What about the face?
3 to 5.
3 to 5 days.
3 to 5. Now, this is a tricky one. What about tissue adhesives? When do you take them out?
Does it remove on its own?
Do you take? Yeah, you.
Exactly. The most important thing is make sure you don't get it wet. That's all. Okay? If you get it wet, and that's it. It's going to dehisce. Okay. Patient that's got a wound, you want to give them tetanus shot, right? Just remember that when you come to medicine with Tisha Moore, tetanus shot, and this is recommendation for when to give tetanus and tetanus toxoid. So don't worry about that. Just know tetanus is very important. Okay, when should you give antibiotics? Wet area. So if you have a wound in between the toes, you better give antibiotics. If it's just immunocompromised, you better give antibiotics. Open fracture, you better give antibiotics. Puncture wounds, nails to the skin, staph coverage, nail to the bones, pseudomonas. Okay, any questions? I think this is the last part. This is the last one, and I did it on purpose. This is the toughest part of the exam. This one is hard. This part is really hard. So I covered chest pain, DVT, wound care, allergic reaction, disaster is done. So this is the last one, allergic reaction. Allergic reaction, right? Anything that could lead to allergic reaction, drugs, anything could lead to allergic reaction. But the most common one is your penicillin and insect bites, your beads. These two are the most common one, right? You guys see this all the time. When you go to the hospital, they'll ask them, do you have any allergy to medication? Oh, I'm allergic to penicillin, okay? And if you have allergy to penicillin, what medication can I give them? What antibiotics?
Clinda.
Or nope. For pre-op, preoperative, antibiotics before surgery. If I can't give penicillin, what do I give? Clinda is number one. That's number one.
Fluoroquinolone.
Nope.
Except
Cephalosporin.
You got to cover MRS. You got to, never mind, you gave it away.
Banco.
Vanco?
Benco, yeah, Benco. So it's penicillin. If they have allergy to penicillin, then you want to give clindamycin. If they can't take clindamycin, then you want to give them Benco. Okay. So, I told you guys to read, I think the chapter on hypersensitivity. You have to know this, and the only thing you have to know here is that what is type 1, what is type 2, what is type 3, what is type 4. Type 1 is IgE mediated, well, that's your true anaphylactic reaction, right? IgE, mast cells being released, histamine being released. Type 2 and type 3 are kind of similar. Yet they're both IgG and IgM, both of them, IgG, IgM. The only difference, this one is a targeted tissue. It targets a tissue, or a cell, an organ, whereby, 3 is a systemic problem. It affects the entire body. Okay, but they're both IgG, IgM. These two right here. This is more, immune complex mediated, and this is why it's cytotoxic, okay, mediated. And the last one is your delayed reaction, or they call it delayed hypersensitivity, which is caused by T cell mediated. And examples would be poison ivy or PPD. So another way to look at this is like your number 1 is easy. Type 1 is easy. Anaphylactic reaction, IgE, that's done easy. Type 4 is also very easy. T cell, okay, and basically delayed reaction, poison ivy, PPD, and stuff like that. That's very easy, right? Or graft rejection, right? It's delayed. It's just a delayed reaction, right? The one that's going to get you is 2 and 3, okay? Most of the time, most of the number 3 is really, how do I say it? It's really seen in people that have autoimmune disease that is systemic. So autoimmune disease that is systemic, you see this a lot, like your rheumatoid arthritis, your lupus and stuff like that. But with the type 2, because it's targeting a specific cell, this right here, it's not really autoimmune, but the only exception is when you have autoimmune hemolytic anemia, okay? But if you think about it, it's really targeting the blood vessel, one thing, whereby when it comes to rheumatoid, it targets everything. It can affect your heart, it can affect your lungs, it can affect your joint, affects a lot of things in your body. So 3 is systemic, whereby 2 is just specific targeted cell, okay? So with type 1, so what happens is that you have some kind of allergic reaction, penicillin B, all right? So what's going to happen is that, the B cells will release your IgE. Your IgE will activate your mast cells and histamines, and then you're going to get your allergic reaction. So that's where you get that, okay? Again, don't forget type 1 IgE, type 2 IgG, IgM, type 3 IgG, IgM, but this is systemic. This one is targeted cell. This is cytotoxic, and this one's immune complex, especially autoimmune, and this one's your delayed reaction. More examples: bee sting, latex allergy, and stuff, penicillin, okay? Type 2, your hemolytic anemia, go pasture, hyperacute, not chronic graft rejection, hyperacute rejection. And basically type 3, it's your lupus, your RA, and stuff like that. And type 4 is right here. Okay, so when it comes to contact dermatitis, which one is that one? What do you think?
4.
Type
4.
Type
4.
4.
That's right, type 4. Rheumatoid arthritis or vasculitis. That's 3. Cryoglobulinemic. Remember, cryoglobulinemic is really affected, especially in people that's got hepatitis C, like it affect the liver. So it's targeted. Okay, so that's your type 2, and obviously your anaphylaxis is your type 1. Okay, just to reinforce this, type 1 hypersensitivity, IgE, boom. You have mast cell that's been denigrated, and you have release of histamine, and you're going to get your anaphylactic reaction. Okay, type 2, I just talked about that, and type 3 and type 4, sick of time. Okay, another thing I want you guys to know real quick when it comes to anaphylactic reaction, when it comes to treatment, there's something called H1 receptor, H2 receptor. H1 receptor, what they do actually is smooth muscle contraction. They contract the muscles. H1 receptors, right? They contract the muscles. Whereby H2, they causes gastric acid secretion. So when patients have an allergic reaction, okay, the last thing you want is vasoconstriction. That's the reason why you got to give them what? H1 blocker. You guys get it? And your examples of the H1 blockers are listed here. Okay. Your ranitidine and your Benadryl. This is your Benadryl right here, Benadryl. Okay. That's your H1 blocker, and that would not relax or cause vasodilation. Okay. Your H2 blocker would prevent the secretion of gastric contents. Let me stop here. Any questions?
Yeah, I had a question, Dr. Sam.
Yeah.
Doesn't epi cause vasoconstriction? Isn't that first line?
Is it epi?
Yeah.
Yeah, that's right. Yeah.
So you said that's bad. Okay. I'm sorry. You said vasoconstriction is bad. Is it like a different type of vasoconstriction then than like what
I
that's
think
causing? Because you said it's bad.
constriction. I think you meant bronchoconstriction.
Oh, okay. Okay.
My fault. I apologize. H1 in the lungs, sorry. That's what I'm saying. Smooth muscle contraction in the lungs.
Okay.
Guts, right.
Okay, that makes more sense. I got you. Thank you.
Okay. You when it comes to the lungs, the last thing you want, right, is to constrict it. So you don't want an H1 agonist. You want H1 antagonist or blocker. Right? Make sense? Any questions?
Yeah, definitely.
All right. Are we good? All right. All right. So almost done. Okay. So basically, when it comes to urticaria, okay, this is very simple. Urticaria is pretty much, you have mast cells that have been released and it's causing vascular permeability only to the skin. So basically, when you have allergic reaction to something and your histamine that has been released is released only just to the epidermis, only just to the skin, that's your urticaria. You're going to see hives and wells, okay? And in treatment, when you see urticaria, it's your topical antihistamine, topical Benadryl, or if you're very severe, you can give a steroid. But anytime you see urticaria, your treatment is your antihistamine. Okay, urticaria is pretty much, you have, allergic reaction that's localized to the skin. Any questions? We're good? Okay. I can't see your faces because I don't know what's going on with my thing. It's like weird. Are we good?
Very good, very good.
Okay, good. The next one is when you have allergic reaction that involves the skin and the subcute. That's what's called angioedema. Okay. Angioedema is when you have allergic reaction, okay, that involves the skin and the subcute. So pretty much it's like a urticaria. It's urticaria that's getting worse, and advanced into angioedema. So it's affecting subcute now. Okay. And basically what you're going to see is going to affect the lips, the eyes, the tongue, and the hands. And everything will be very swollen. The eye will be swollen, the lips will be swollen. Okay. So that's your typical angioedema. Okay. And the best treatment for this is to give sub-Q, okay, epinephrine, okay, especially for laryngeal edema and bronchospasm. Sub-Q epinephrine. Okay. Sub-Q. Okay. Anaphylaxis. When you have anaphylaxis, okay, let me just go to the definition. Sorry. Go back. When you have anaphylaxis, okay, you have allergic reaction that is involving the skin, the subcute, and the deep layers, the mucosa. The main thing I want you guys to know here, okay, with anaphylaxis is that anaphylaxis affect multiple systems. Okay, usually starts with the respiratory, usually starts with the skin, respiratory, and then vascular. So it always involves multiple systems. If the reaction is only just to the skin, that's not anaphylaxis. If it's just to the lungs, that's not anaphylaxis. It's got to involve at least 2 or more. Okay, so let's do this. So life-threatening events, you have pruritus. What organ is that?
Skin.
Skin. Is that anaphylaxis?
No.
No. Flushing. What organ is that?
Skin.
Skin. That's still not anaphylaxis. Urticaria. What organ is that?
Skin again.
Skin again. That is still not anaphylaxis. What about this? Fullness in the throat.
The oropharynx and respiratory.
Anaphylaxis, yes or no?
Angioedema.
That's right, angioedema. That's right. Now anaphylaxis, that's it. So now you have skin and now you have respiratory. That's anaphylaxis. Anxiety, nervous system. Chest tightness, that could be respiratory or cardiovascular. Shortness of breath, that could be respiratory or cardiovascular. Decreased level of consciousness, that's the brain, right? You guys see that? So you need multi-system. It's not just one, it's multiple, 2 or more. Okay, so that's very important that you remember that. Okay, let's keep going. This is where you guys are going to have a difficult time on the exam on Thursday. So I'm going to spend some time here and I'm going to end it after this one. I think that's it. This is the last one. Last one. Yeah, that's it. Okay. So listen, I'm going to give a couple of scenarios. I want you to tell me what's the best treatment. You have a patient that's just been stung by a bee, okay? They having urticaria, they having angioedema. What's the next thing you should do?
Subcutaneous epinephrine.
Okay.
Establish airway.
Right. Establish airway. That's the most important thing. Establish airway first. Okay. Establish airway. But I just told you this patient is having urticaria and angioedema. And angioedema. What is that?
Anaphylaxis.
Exactly. So if they have an anaphylaxis, after you check the airway and the airway is good, it's fine, it's beautiful, nothing is wrong with the airway, they're talking to you fine, okay? What's the best initial treatment for this patient?
Epinephrine.
Wrong.
Antihistamine.
Wrong.
If hypotensive, give a bolus of intravascular
What's
fluid.
the first initial treatment for a patient like this?
No steroid. I don't know.
No.
Bronchodilatation.
The answer is there. Someone said it already, but I just want that person to be more specific.
Intramuscular.
Intramuscular.
Benadryl.
Intramuscular epinephrine. Because you could give sub-Q epinephrine. Okay. So it's gotta say I am, not IV epi, I am epi. Does that make sense? So don't tell me epi because you're gonna get it wrong. You gotta say I am epi. Because you could have IV epi on the exam, you could have sub-Q epi on the exam. So you gotta make sure you say I am epi. Okay. So you have this patient is talking to you, okay, and you notice that they having urticaria and angioedema. So you give them, boom, I am epi, right? And 5 minutes later, they feel that the angioedema is not getting better. You feel like the angioedema is not getting better. What's the next thing you should do?
Do it again.
Try again.
Do it again. Do it again. Give on the epi. Okay. And what would give it away that this patient is having angioedema, they're going to tell you that they're wheezing, and they have difficulty breathing, they're uncomfortable. So basically when you hear things like that, that's your chance to give epi. And if it's not getting better, do it again. So after you do it again, now they're feeling better. They could build, they're breathing better, they're feeling better. The next thing you have to do is to go to your second line. And your second line is to go down the line here. You give steroid which is an anti-inflammatory. Then you want to give your antihistamine, your H1 blocker, your H2 blockers. If they're still wheezing, you want to give bronchodilator, okay? And also, if the wheezing is pretty bad, you want to give them magnesium sulfate. If you think that they are becoming hypotensive, you want to give a bolus of IV fluid. Okay. What if this patient, now is not having stridor, or the uvula and the soft palate is becoming very swollen?
Intubate?
Intubate. So let me give you another scenario. You have a patient that was just given penicillin, and all of a sudden you notice that the patient is having stridor, their airway is closing up. Which one should you do first, epi or intubation?
Intubation.
Does everybody agree or disagree with that?
Agree. You have to breathe. You have to be able to breathe.
You gotta be able to breathe. So now, don't get me wrong; they do both together. Like someone is intubating and they're doing IM, they do it together. But if
What was the question, Dr. Sam?
The question is, if a patient is having uvula or soft palate that's swollen or that's swelling, and they have stridor, which one should you do first? Give epi or do intubation? What's the answer? You asked me a question.
Intubation, yeah.
Why?
Because it's swollen, so they need air. They need more room for air to pass. I guess since it's swollen, it's causing obstruction.
Okay. Give me 1 minute. Give me 1 minute. I was see something. Okay. So let me give you another scenario. You have a patient that has got a muffled sound. Okay. Is that a good thing or a bad thing?
Muffled breath sounds?
Yes.
Bad.
Bad, right? And they talking to you, but they have a muffled breath sound, they have urticaria, what do you do next?
I am happy.
That's right. I am happy. So what I'm trying to say is, anytime, if the airway is established and the airway is fine, they don't have swelling of the palate, swelling of the uvula, they have no stridor. The first you want to start with is to give that, epi, to help them, calm down the angioedema and urticaria, the anaphylactic shock they're having, and if it's not helping, give another one, until they feel better. Once they start feeling better and they're improving, that's when you're going to go down the line and give steroid, antihistamine, which is H1 blocker, H2 blocker, bronchodilator, magnesium sulfate. That's when you go down the line. Okay. If you see, the patient is now wheezing, bronchodilator. Okay. Patient's hypertensive, IV fluid. Okay. So right here, that's pretty much your glottis open, your epiglottis look nice. Look nice. Look at this one, right? Everything is very swollen, and you can see the airways closing up. Okay. This right here, you do not give epi on this one. You want to do intubation first. So when you have anaphylactic reaction, okay, and the airway is closing, the first you want to do is to do intubation. But if the airway is not closing, and how do you know the airway is closing? You're going to see swollen uvula, like right here, swollen uvula right here. You're going to see the closure of the glottis, okay? Epiglottis is going to be swollen too, right? The palate, soft palate, going to be swollen. When you see swelling, okay, in the airway, the first thing you do is intubation. But if the breath sound is muffled a little bit, that means they have angioedema. That doesn't mean the airway's closing. Then you want to give them epinephrine and start with that and keep going. But if you notice this patient, they have a stridor and they have a swollen palate, the first thing is do intubation. Then you want to give them epi. Then you want to get them to ICU. Okay. And once started getting comfortable, then you want to start with the second line. Go down the line, steroid, H1, H2, blocker, bronchodilator, especially when they're wheezing, and magnesium. Okay. So I wanted to see if I could play this. It's not working. It's not working. It was working before. Anyway, that's it. Any questions?
Yeah, I had one question actually.
Yes.
You had one slide that you were like quizzing us about all different types of closures, like suture, tissue adhesive.
Yes.
I think one of your questions said least tissue reactivity. Shouldn't that be the adhesive? You said it was staples, so I'm a little confused.
Let me see.
One said low and one said least.
It said low.
Let's see. Where are you? Where are you? Good stuff. Say the least reactives, I said?
I thought you said least, but apparently you just said low tissue reaction.
John, I sent you the picture.
Thanks.
Let me look for it. I'm trying to find it. Oh, right here. Okay. Which one is low reactivity? Oh, you're talking about that. Right? Is that what you're asking?
Oh yeah, sorry. Yeah, I am talking about that. I just thought it would be adhesive because it's low tissue reactivity.
Adhesive what? Adhesive tape or adhesive tissue adhesive?
I thought she had adhesive tape in the lecture as the lowest reactivity.
That is true.
I see the mix up. Staples is low, the adhesive is least.
There's two. One says least reactive adhesive tapes, but then there's a low tissue reactivity, which is staples.
I see. Okay. All right. Sorry.
Are we good?
Yeah.
I think that's like because of allergies that the people are less allergic or would have a reaction to metal as opposed to a synthetic tissue tape, where you can get versus the other. I don't know. That's how I interpret it.
Right. Any other questions? Let me just make sure I covered everything. I'll make sure I cover everything. While I'm looking for my list of things I need to cover, do you guys have any questions for me? If you have no questions, what do you guys think about the reviews? Was it helpful? Did he really narrow things down for you, help you out?
Very helpful.
I love it.
Very helpful. Thank you, Dr. Sam.
As always.
Dr. Sam, I do have a quick question for you. Regarding intubation, like I know that the ABCs think so but in the lecture, like the first means of trying to open the airway were the jaw thrust and the head lift, chin lift, head press. So, but when you say intubation, that's like literally doing an ENT tube. So which do you do first? Do you do the less invasive first? And if that doesn't work, you move to the NG2, or are you referring to like when you're in such a state with the angioedema, everything's so closed up, you have no other choice?
Right. So basically, when a patient anaphylaxis, and I could put a tube into the glottis, all right, I'm doing that right away. I'm doing intubation, and that intubation, you have to place them in a sniffing position, okay,
Yeah.
put a tube down your throat, okay. Now, if that glottis is so closed, the airway is completely closed, and you can't get to the airway anymore, at that point, you have to do cryocardiectomy, where you cut the skin.
Right. No, I understand that. I'm just saying the protocol that was given in the lecture was like, she talked about doing manual manipulation of the jaw to take the tissue off of the trachea.
Got it. Yes.
Versus going straight into intubation, that like intubation was like kind of like your last ditch effort when the preceding techniques didn't work.
Right. We are talking about emergency. Someone is going to die.
Okay, all right. I just want the context of the question then.
Yes, 100% correct. Yes.
Perfect. That's all I wanted to know. Thank you. Thank you for the review too. Very much.
I want to say one more thing that I forgot to mention. If you have a patient that's got an infection, right, in the foot or somewhere, what do you do first? For people that are still here, a patient's got an infection in the foot, for example. What do you do first?
Make sure the patient's stable.
Okay, keep going.
X-rays and labs.
X-rays, labs, keep going.
Empirics.
Antibiotics, right? Okay. All right. Just want to
CT. Culture.
Culture, CT, all this other stuff.
Work up if it's very bad.
Say again?
Septic workup if it's bad.
Yeah. Septic workup is if it's really, really bad. Absolutely. Okay. All right. Let me just make sure. Let me see. Let me see. Okay. I'm coming just to make sure I covered everything, and I beautifully did. Good night, everybody. I hope this was helpful.
Thank you, Dr.
Thank you.
Thank you.